Episode 43, A Young Marine Goes Down. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Here's the case. A 24-year-old active duty male Marine presents to the emergency department by ambulance. About 10 minutes into his run, he developed generalized itching with diffuse hives, palpitations, and lightheadedness. He sat down to rest, tried to stand up, and nearly lost consciousness. When emergency medical services arrives, they find his blood pressure to be in the 60s over palpable. In the field, he received 1 liter of normal saline, 0.3 milligrams of intramuscular epinephrine, and 50 milligrams of intramuscular diphenhydramine. By the time he reaches the emergency department, his pressure has improved to 113 over 69 with a heart rate of 87 and oxygen saturation at 98% on room air. There was no wheezing, no dyspnea. In the emergency department, he received another liter of saline, 125 milligrams of IV methylprednisolone, and 50 milligrams of IV ranitidine. He is subsequently discharged with an epinephrine auto-injector, fexofenadine, and a 5-day course of oral prednisone, and a referral to the allergic clinic. So the only physical exam that was offered by the authors in this case was that his respiratory exam was normal. Now, my differential diagnosis included cold-induced urticaria, cholinergic urticaria, exercise-induced asthma, exercise-induced anaphylaxis, and anaphylaxis from an insect sting. This case was published in the Case Reports in Medicine by Jaqua, Peterson, and Davis out of Tripler Army Medical Center in Honolulu, Hawaii in 2013. I'm Scott Hull, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in November of 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, so 3 weeks later, he is seen in the allergy clinic. They take a meticulous history, and it reveals that this was not a one-time event. This Marine reported a 3-year history of diffuse itching and hives during or shortly after running. He estimated 20 to 25 episodes over 3 years. He had been seen in an acute care clinic multiple times and treated with diphenhydramine, which would resolve his symptoms. But on 4 separate occasions, including the most recent one, his symptoms escalated beyond hives into full-blown anaphylaxis. His symptoms were not consistently associated with any food, medication, or environmental condition. He typically ran in the morning on an empty stomach. He never experienced symptoms while weightlifting, only while running. Prophylactic H1 antihistamines had previously provided no significant benefit. So, in summary, there was a young, healthy athlete with recurrent exercise-specific anaphylaxis, no identifiable food trigger, and incomplete response to antihistamines. The ultimate diagnosis was exercise-induced anaphylaxis, and I'm going to quote the authors. Given the unpredictable and potentially lethal nature of exercise-induced anaphylaxis, he was advised to avoid running, carry an epinephrine auto-injector at all times, and exercise with a partner trained in symptom recognition and administration of an epinephrine auto-injector. He was also instructed to avoid food, anti-inflammatory medications, and alcohol a minimum of 4 hours prior to exercise. Additionally, he was advised to engage in a graded exercise program, and at the first indication of flushing, itching, hives, or lightheadedness, or shortness of breath, to discontinue exercise, self-administer epinephrine, and seek immediate medical assistance. That's the end of the author's quote. Okay, a couple of key takeaways from me. Exercise-induced anaphylaxis is a rare syndrome first described in 1980. It presents with symptoms during or shortly after physical exertion, including fatigue, warmth, itching, flushing, and urticaria that is typically large, 10 millimeters or greater in diameter. And in severe cases, it can progress to angioedema, bronchospasm, airway compromise, and cardiovascular collapse. Jogging or running is the most common precipitant, but a wide range of activities can trigger episodes. The pathophysiology is incompletely understood. What we do know is that mast cell degranulation with histamine release play a central role. Studies have demonstrated elevated plasma histamine levels during episodes of exercise-induced anaphylaxis. Beyond that, several mechanisms have been proposed. Exercise-induced changes in blood flow distribution, alterations in antigen presentation, shifts in blood pH, and a particularly relevant to the food-dependent variety, increased gut permeability during exercise that may allow greater allergen absorption. The authors discuss a distinction here between exercise-induced anaphylaxis and cholinergic urticaria because they can look similar. Cholinergic urticaria typically produces small punctate wheals, typically just a few millimeters in size, and is triggered by any rise in core body temperature, including passive warming like a hot bath. Exercise-induced anaphylaxis produces large wheals and is triggered specifically by exercise, not by passive heating. Of course, cholinergic urticaria rarely progresses to anaphylaxis, whereas exercise-induced anaphylaxis by definition certainly can. There's this subtype that I wanted to discuss, which I did not understand before this article, and that is food-dependent exercise-induced anaphylaxis. In these cases, anaphylaxis occurs only when exercise follows ingestion of a specific food, usually within a few hours. Neither the food alone nor the exercise alone trigger the reaction. Known cofactors that can lower the threshold for an attack include aspirin and other anti-inflammatories, alcohol, high heat and humidity, and cold exposure. In our Marine's case, the history did not point to a specific food trigger because he usually ran when he had fasted. So his presentation was more consistent with non-food dependent exercise-induced anaphylaxis. The allergy team counseled him to avoid food, anti-inflammatories, and alcohol for a minimum of 4 hours of exercise because these cofactors could potentiate any episodes. And I want to comment specifically on management as outlined by recent guidelines. It's reference 1 from the American Academy of Allergy, Asthma, and Immunology. This is a direct quote. Patients in whom the diagnosis of food or drug-dependent exercise-induced anaphylaxis is confirmed should be advised to avoid exercising in proximity to a cofactor such as a food or drug that can induce episodes of exercise-induced anaphylaxis. The length of time that affected subjects should not exercise after food consumption is controversial. A waiting period of at least 4 hours is generally recommended. Patients with exercise-associated anaphylaxis should exercise with a partner who is aware of their condition, carries a cell phone, and is capable of treating an episode of anaphylaxis if it should occur. Injectable epinephrine should be prescribed and carried by the patient, and medical identification jewelry should be worn. It is recommended that patients avoid exercising on warm, humid days, avoid concomitant use of aspirin and aspirin-like drugs, and cease activity with the onset of premonitory symptoms of anaphylaxis, such as flushing, pruritus, or urticaria. Emergency management of an episode of exercise-induced anaphylaxis is similar to the management of other types of anaphylaxis and might require administration of epinephrine, IV fluids, oxygen, antihistamine, corticosteroid, endotracheal intubation, and other resuscitative measures. Okay, practice questions for you. Question 1. A 22-year-old soccer player presents to the athletic training room after developing diffuse urticaria with large wheals greater than 10 millimeters, lightheadedness, and hypotension during a practice session. She reports similar but milder episodes of itching and hives during running over the past 2 years. She denies symptoms with hot showers or passive warming. Her teammate, a volleyball player, also develops hives during exercise but describes small punctate 2 to 3 millimeter wheals that also occur when she takes hot baths. Which of the following best distinguishes the soccer player's condition from her teammate's condition? A. The soccer player's condition is triggered by any rise in the core body temperature, while her teammate's is triggered only by exercise. B. The soccer player's condition produces large wheals and is triggered only by exercise, while her teammate's condition produces small wheals and can be triggered by passive warming. C. The soccer player's condition is mediated by IgG antibodies, while her teammate's is mediated by IgE antibodies. D. The soccer player's condition is associated with bronchospasm more frequently than other causes of anaphylaxis. The correct answer here is B. Exercise-induced anaphylaxis is characterized by large wheals greater than 10 millimeters and is triggered specifically by exercise, not by passive warming. Cholinergic urticaria produces small punctate wheals of 1 to 3 millimeters and is elicited by any elevation in core body temperature, including passive heating. This distinction is a key diagnostic differentiator. Option A reverses the condition. Option C is incorrect, as exercise-induced anaphylaxis involves mast cell degranulation with histamine release. IgG-mediated mechanisms are not a distinguishing feature, and option D is incorrect because bronchospasm occurs in exercise-induced anaphylaxis, but is considered less frequent than other etiologies of anaphylaxis. Okay, question 2. A 28-year-old recreational runner is diagnosed with exercise-induced anaphylaxis after presenting with recurrent episodes of urticaria, pruritus, and 1 episode of anaphylactic shock during running. He has no identifiable food triggers and typically exercises in the morning on an empty stomach. Which of the following is the most important component of his management plan? A. Prescribing a daily H1 antihistamine with instructions that it will reliably prevent future episodes. B. Advising that he can continue his current exercise routine as long as he avoids anti-inflammatories. C. Initiating a beta agonist inhaler for prophylactic use before exercise. D. Ordering exercise challenge testing before any management can be initiated. E. Recommending he always carry an epinephrine auto-injector, never exercise alone, and stop exercising at the first sign of symptoms. The correct answer here is E. The cornerstone of exercise-induced anaphylaxis management is avoidance and preparedness. Always carrying an epinephrine auto-injector, never exercising alone, and ceasing exercise immediately at the first sign of flushing, itching, hives, or lightheadedness. Option A is incorrect because H1 antihistamines are inconsistently effective and should not be presented as reliable prevention. Option B is dangerously incomplete. While anti-inflammatory medication avoidance is appropriate, continuing the same exercise routine without other precautions would be unsafe. Option C is incorrect, as beta agonists have not demonstrated benefit in preventing exercise-induced anaphylaxis attacks. Option D is incorrect because the exercise challenge test is not required for the diagnosis. The diagnosis is clinical and based on a meticulous history. Question 3. A 30-year-old triathlete develops anaphylaxis during a training run 2 hours after eating shrimp. She reports a prior similar episode after eating shellfish before cycling. She has eaten shrimp on multiple occasions without exercising afterward and has never had a reaction. She has also completed numerous training sessions without eating beforehand and has never had symptoms. Which of the following is the most likely diagnosis? A. Exercise-induced anaphylaxis, the non-food dependent variety. B. Shellfish allergy. C. Food-dependent exercise-induced anaphylaxis. D. Cholinergic urticaria. The correct answer here is C. Food-dependent exercise-induced anaphylaxis is characterized by anaphylaxis occurring only when exercise follows ingestion of a specific food. Neither the food alone nor the exercise alone trigger the reaction. This particular patient tolerates shrimp without exercise and tolerates exercise without prior shrimp ingestion, but develops anaphylaxis when there is a combination of the two. Okay, next question. A 26-year-old active duty soldier has been diagnosed with exercise-induced anaphylaxis. His allergist discusses prophylactic pharmacotherapy options. Despite taking cetirizine daily, he continues to have breakthrough episodes of urticaria during exercise. Which of the following statements regarding prophylactic pharmacotherapy for exercise-induced anaphylaxis is most accurate? A. Beta agonists have been shown to reliably prevent exercise-induced anaphylaxis. B. H1 antihistamines may reduce symptoms, but usually are not completely effective, and no prophylactic pharmacotherapy has been validated in randomized controlled trials. C. Phosphodiesterase inhibitors are considered first-line prophylactic therapy. D. Oral corticosteroids taken daily are the standard of care for long-term prevention. E. Prophylactic pharmacotherapy is unnecessary if the patient carries an epinephrine auto-injector. The correct answer here is B. No prophylactic pharmacotherapy for exercise-induced anaphylaxis has been systematically studied in randomized controlled trials. H1 antihistamines may reduce symptom severity but are usually not completely effective. Beta-agonists and phosphodiesterase inhibitors have not demonstrated benefit. Other agents reported anecdotally include leukotriene inhibitors, misoprostol, and oral corticosteroids, but none of these have been directly validated. Question 5. A sports medicine physician is evaluating a 25-year-old athlete who reports 3 episodes of generalized pruritus and urticaria during running over the past year. The physician suspects exercise-induced anaphylaxis. Which of the following is the most appropriate diagnostic approach? A. Serum tryptase levels during an asymptomatic clinic visit will confirm the diagnosis. B. A maximal graded exercise treadmill test must be performed before the diagnosis can be made. C. The diagnosis requires a meticulous clinical history, exclusion of other potential diagnoses, and is primarily a diagnosis of exclusion. D. Skin prick testing to confirm aero allergens will confirm the diagnosis of exercise-induced anaphylaxis. E. A positive metacholine challenge test is diagnostic. The correct answer here is C. Exercise-induced anaphylaxis is a clinical diagnosis of exclusion. It requires a meticulous history, including character, intensity, and timing of exercise, associated environmental conditions, food intake, and medication use. And exercise challenge testing is not required for the diagnosis and is often not performed given the lack of validated protocols and the poor reproducibility of symptoms. Option A is incorrect because a baseline tryptase during an asymptomatic period does not confirm a diagnosis of exercise-induced anaphylaxis. Option D is incorrect because aero allergen skin testing does not diagnose exercise-induced anaphylaxis. And a methylcholine challenge test is for airway hyperreactivity, not exercise-induced anaphylaxis. Thank you.